Assalamu alaikum. I am Dr. Yunus, PGR, Pulmonology Department, Khyber Teaching Hospital. On behalf of our registrar, Dr. Shahid Zia, who is not here because of his exam, I will present his topic, the frequency of pulmonary hypertension in patients with interstitial lung disease. Introduction. Interstitial lung disease, also called as a diffuse parenchymal lung, that is DPLD, having the burden of about 5.1%. Pulmonary hypertension, among other, is a common extrapulmonary complication of the disease. It develops in significant number of patients with ILDs due to the effect of chronic hypoxia and the focal destruction of capillaries in fibrotic lung tissues. Studies provide an evidence of pulmonary hypertension frequency in ILD in our setup and highlight the need for preventive strategies. Early detection of the pulmonary hypertension in ILD is crucial, as its presence is commonly associated with higher morbidity and mortality and hospital burden. The study design, it was the cross-sectional study in the pulmonology unit of Khyber Teaching Hospital. The duration was 6 months, that is from September 28 of 2019 till March 27th of 2020. Sample size was 95 with 95% confident interval and 7% margin of error and prevalence of 14%. Sample technique was consecutive non-probability sampling. Patient included in our studies were all the patients having ILDs as per operational definition due to any cause and any pattern, having symptoms of at least 6 months duration. Both genders, male and females, were included, age between 30 and 70. Patient excluded were those with ILD having active TB, patient with the chronic LVF, bronchiectasis. These acts as a mimicker of ILD, so were excluded from this study. Patient with pulmonary hypertension and pulmonary hypertension due to patient with primary pulmonary hypertension and pulmonary hypertension due to thromboembolic disease were also excluded. Patient having pulmonary hypertension due to chronic hypoxic lung disease like COPD were also excluded. Ethical approval, data collection was started after ethical approval obtained and written informed consent taken from the patients. Patients' biodata were recorded after clinical history and examination. Transthoracic echo were performed by cardiologists for the presence or absence of pulmonary hypertension using conventional echocardiographic equipments. To eliminate bias, all the echocardiography were performed by, in KTH by a trained cardiologist with the same echocardiographic equipments. Confounders were eliminated by excluding the condition as mentioned in our exclusion criteria. Pulmonary hypertension, if present, were graded into mild, moderate, and severe to the estimated pulmonary arterial systolic pressure, as between 40 to 50 as mild, 51 to 60 moderate, and more than 60 were taken as severe pulmonary hypertension. All the information were recorded in structure proforma. All the data collected in design proforma were entered and analyzed by using SPSS 16. Categorical variables like gender and pulmonary hypertension were presented as frequency and percentages. Numerical variables like age were computed through mean plus standard deviation. Pulmonary hypertension was stratified among age, gender, smoking history, and duration of the disease to see the effect modification. Post-stratification chi-square was applied. P-value of less than 0.05 were considered statistically significant. All the results were presented in the form of tables and graphs. A total of 95 patients were included in our studies from either gender with ILD were included in this study. There were 41 males and 54 female with ratio of 1:1.31. Out of 95 patients with ILD, there were 27 patients shows pulmonary hypertension, while 68 were without pulmonary hypertension. Out of 27 of pulmonary hypertension in ILD, 7 have mild, 10 have moderate, and 10 patients have severe pulmonary hypertension. Gender-wise distribution of pulmonary hypertension shows that gender has a little role in over pulmonary hypertension. There were 1.7 patients having pulmonary hypertension in males, and 25% were females. Similarly, pulmonary hypertension was found in more in the smoking patient, and duration of disease of more than 1 year patient, but statistically insignificant. This is the gender-wise, smoking, and duration-wise distribution of the patient, but the p-value of was insignificant in all these cases. So pulmonary hypertension defined by a mean pulmonary arterial pressure of more than 25 is an important complication to ILD. The gold standard for diagnosis of pulmonary hypertension is the right heart catheterization. Echocardiography remains the best non-invasive procedure in the pulmonary hypertension. Almost all ILDs are having pulmonary hypertension as a complication depending on the severity of the disease. Pulmonary hypertension is one of the potential causes of dyspnea and exercise limitation in patients with ILD, and it's associated with worse prognosis. In former studies, the prevalence of pulmonary hypertension in ILD has shown a great variation dependent on the patient population and the design of the study. E.g. in sarcoidosis patient, 5.7% patient had pulmonary hypertension based on echo, while prevalence of 48% was reported in patients with IPF transplant candidates. Number of studies have investigated lung transplant candidates in whom right heart catheterization were done routinely, but lung transplant candidates only constitute a small group of patients at referral centers, that is less than 4% at our institution. And they have particularly advanced lung disease. The prevalence of pulmonary hypertension may be notably higher than in ILD patient in general. In a prospective observation studies, Luchet et al. Reported that 31.8% pulmonary hypertension out of 88 consecutive patients with various ILD. Another study by Anderson et al. Included 12 patients with mixed type of ILD, and 14% of these have had pulmonary hypertension. In a study by Nadnes et al. In a tertiary center, 88 patients with IPF in whom pulmonary arterial systolic pressure were assessed with transthoracic echocardiography. The mean pulmonary arterial systolic pressure ranged from 28 to 116 millimeter of Hg. A study by Henda et al. Of 246 consecutive Japanese sarcoidosis patients who were evaluated for pulmonary hypertension by Doppler echocardiography found that 5.7% of the patients had pulmonary hypertension. Another retrospective study analyzed by large number of right heart catheterization data from patients registered with ultrasound lung transplant registry showed that 46.1% of patients with IPF waiting for lung transplant had pulmonary hypertension. So the present study showed that the prevalence of pulmonary hypertension was 28% in ILD patient at a tertiary referral institute, and that pulmonary hypertension patients have substantially worse prognosis than patients without pulmonary hypertension. Pulmonary hypertension was related to estimated pulmonary arterial systolic pressure, RVSP, longer disease duration, and smoking history parameters, but even corrected for lung function parameters and the presence of ILD, pulmonary hypertension, limited exercise capacity with a clinical relevant magnitude, indicating that pulmonary hypertension is an independent worsening factor in ILD patients. These are my references. Thank you.